Okay, so welcome to week six's video podcast for examine pharma pharma pharmacodynamics in my reaction. So let's go ahead and get started. Just a couple things about me, real quickly. I am a detention officer for kiddos in my area, and I do pass out sometimes, if need be, psychological medications as needed. And this is actually a good time for me to get an understanding of some, in this class in particular, a good understanding for me to see what the understanding of some of these meds are, because I cannot pronounce them at work. Um, so let's go ahead and start with the first section, shall we? Uh, which SSRIs have been approved for use with children and or adolescents? Uh, for what conditions are they approved to treat? So, real quickly, kiddos, even the little ones, let's say even under the age of 10, leading into their adolescent years, they are very hyperactive, and they need a little bit of help, but they also need the mental structure if need be. But if they need help mentally with uh, medications, these medications can assist. So two SSRIs that I found that have been FDA approved are, I can never pronounce these, forgive me, are fluoxetine, which treats depression, compulsive disorders, and panic, as well as bulimia and panic disorders. And I can never pronounce this one, forgive me. Uh, escita, escitalopram. Escitalopram. Um, Escitalopram, yeah. Which is used to help with general anxiety disorders. Um, some Those are just two FDAs that I found, and they are approved to treat. Um, Other medications that have been approved for children and adolescents, and their age, and usually what ages that they are prescribed at. So some medications are stimulants or antipsychotics that I found. Let me forgive me on how I pronounce this. So I have ampha amphetamine amphetamine excuse me, amphetamine. Excuse me, I'm sorry. Uh, which could usually be prescribed three at 3 years or older, 3 years of age or older. And this is to assist these kiddos with their attention span. Another one that I have is Risperidone, which could be prescribed at age 5 or older, and it does assist in bipolar disorders or irritability, especially with those kiddos who do have that irritability. Next I have is clopro clopromazine clopromazine, which can be prescribed at 6 months or older, which is actually quite incredible that we can prescribe at that age, at 6 months or older. And it is usually for kiddos with behavior issues. Next I have halo haloperidol. Her, Haloperidol. Oh, I can never pronounce these. Forgive me. It's usually prescribed at 3 years or older for psychosis, schizophrenia, antipsychotics, or Tourette syndrome. When I say antipsychotics, it could assist those kiddos who've had trauma in their life. Like I said, I work for juveniles in my local area, and these kiddos have seen some terrible things, and this can assist those in that. Some downfalls of some of these meds, they can, if used in a long period of time, and if not treated, bipolar disorder can begin with these kiddos if not treated, and uh, and if not, cognitive and mental health can be affected. These medications do help a lot. What other medications? Okay, I've done that. What are the most important advocacy questions to ask your client and their caregiver regarding a child on psychotropic medication? So some questions that I were if I were not a psychologist but a psychiatrist, excuse me, um, I would rather, if me personally, I'm a believer that medication isn't always the answer for some of these kiddos. I believe in firm structure for these kiddos. If these kids need something to do, they have to sit down and do it. Sometimes it could be simple applied behavior analysis, positive reinforcement for kiddos who in order for them to do what is needed. Do homework. If you are able to do homework, you can go and have recess. Things like that. Going outside, etc., playing outside. Those can be some good positive reinforcement elements. What else? But on the flip side, medication can be a very, very, very powerful tool for these kiddos due to a chemical imbalance. Um, no blame on the parents requesting to put their children on medications, but if medication is a solution, I believe in 6 A's that as a therapist that we would have to use with our kiddos. Our first A would be availability. Is the medicine going to be available for the child as needed? Accessibility. Does the family have access to the medication? Is it accessible? If it's too much, if it's too little, things like that. Approachability towards the therapist. I would rather build rapport with these young people before I start saying, "Here, take this medicine and relax for the rest of the day, and this is what I need you to do." I'd rather be able to build rapport and get a positive and endorse positive reinforcement to these kiddos than to have them take medicine. Acceptability. How acceptable is everybody on par for these medications? At my job, for example, a big one is trazodone. That medicine, I'm surprised on how as soon as a kiddo takes it, he is knocked out within a few hours, and nothing can wake him up unless you are physically prompting the kiddo. Um, and what is this last one? Appropriateness. How appropriate is the medicine? Is it really appropriate for these kiddos' age? Have their experiences been treated prior to taking medicine? Do they need it? Or can cognitive behavioral therapy, which takes time, assist? Okay. What are the most important advocacy questions? I just kind of answered that. Imagine yourself. Let me see. What are some symptoms of being? Okay, which drugs? Okay, so the next section here says I have to imagine myself as an MFT working with a child and his or her family who is being treated for attention disorder. Reflect on your response to the following. What are some symptoms of being medicated? Well, some symptoms of being medicated or having to be medicated. Obviously, if I'm dealing with a kiddo who has a attention disorder, um, one of the things is that I've learned as a in my position is that you have to be able to like again I go back to the rapport, and one of the biggest things that I've realized with these kiddos depending on their age is you got to find out what they like. And it has to be a very strong positive. If one kiddo really likes playing drums, talk to them about playing drums. Or if they like music, let it be music that can be a positive reinforcer, or movies, or whatever it is. So that we can be able to say, okay, hey, let's talk about what you're needing for if medication isn't really if medication, in my opinion, if it can be avoided, it's a win. Because some of these behaviors that these kiddos get, especially nowadays, could be in school on their they start seeing things on their phone that is completely inappropriate, or they think their world is through their that device, and we can figure things out on that. Which drugs are supposed to treat which symptoms? I've kind of went over some. So let me give you an example of let me give you a non a fictional case vignette. I get little Johnny who is who has in my position. Let's say he attacked a police officer, and and he gets referred to the juvenile system, and he's not on any medications or anything. So there's clearly some at 10 years old. There's a sense of socialism, and when he gets there, he just doesn't listen to anybody. He doesn't listen to he. Only thing he wants in life is what he wants. Maybe maybe sweets, etc. Um, he doesn't want to listen to authority figures. He gets very upset with his family when he is held accountable, things like that. So some maybe some which maybe some form of maybe Risperdal would be very acceptable for that young person for his irritability. Um, let's see, what else do I have here? Has there been an improvement in targeted symptoms since the child started taking the drugs? Time can only tell. If there is improvement for kiddos who start taking these medications, let that be a go getter. I think if we can put them on medication and keep them on to that can and it benefits them and it works for them, let's just keep it on for them. And then ultimately, the only person who can say they're going to stop taking the medications is either the parent at a certain age or the young person. Let's see what else I have here. If not, why continue if not, why continue the child on drugs? Well, like I said earlier, there's going to be a time where the kiddo is not going to need this medicine anymore. He might need it in the future. He may need it as he or she gets older, but he may not need it. That is my presentation. I hope if you have any questions, please feel free to reach out to me. Thank you.